Pheochromocytoma is a catecholamine-producing tumor arising from the adrenal medulla, while paraganglioma arises from extra-adrenal paraganglia. Paragangliomas can occur in the skull base, neck, thorax, retroperitoneum, and bladder, with variable secretory behavior. These tumors are called great masqueraders due to highly variable and episodic clinical presentation. Approximately 25 to 33% of cases are inherited with germline mutations involving RETV, HLN, F1, and SDH genes. Genetic clusters include pseudohypoxia pathways, kinase signaling pathways, and WNT signaling pathways. The classic clinical triad includes headache, profuse sweating, and palpitations in a hypertensive patient. Hypertension may be sustained or paroxysmal and is often associated with anxiety, pallor, and tachycardia. Paroxysms can be triggered by surgery, exercise, positional changes, or even urination. Metabolic effects include hyperglycemia, erythrocytosis, hypercalcemia, and weight loss. Diagnosis relies on measurement of plasma-free metanephrines, which have the highest sensitivity. 24-hour urinary fractionated metanephrines are also highly sensitive and specific. Clonidine suppression test is used in borderline cases to confirm autonomous catecholamine secretion. False positives may occur due to stress, medications like sympathomimetics, levodopa, tricyclics, and beta blockers. Imaging with computed tomography or magnetic resonance imaging is first line to localize the tumor. T2-weighted magnetic resonance imaging is particularly useful for extra-adrenal paragangliomas. Functional imaging includes I123M IBG scintigraphy and gallium-68 DOTATAT EPET computed tomography. Histology shows Zellbelin pattern with nests of neuroendocrine cells and sustentacular cells. Preoperative management requires alpha blockade using phenixybenzamine at 0.5 to 4 mg per kilogram. Blood pressure must be controlled below 160/90 mm of mercury before surgery. Beta blockers such as propranolol are added only after adequate alpha blockade. Definitive treatment is surgical removal via laparoscopic or retroperitonoscopic adrenalectomy. Intraoperative hypertensive crises may require nitroprusside infusion and rapid hemodynamic control. Metastatic disease occurs in 5 to 10% and is defined by lymph node or distant metastases. Management options include chemotherapy using dacarbazine, cyclophosphamide, and vincristine, along with radionuclide therapy. Pheochromocytoma in pregnancy requires surgical removal, preferably in the second trimester, between 4 to 6 months. Syndromic associations include MEN2V, HL disease, and NF1 with earlier onset and multifocal disease. Genetic screening is indicated in young patients, multifocal tumors, and extra-adrenal disease. Clinical takeaway is to suspect pheochromocytoma in episodic hypertension with classic triad and always initiate alpha blockade before surgery.